cardiometabolic medicine. It used to feel relatively static, you know?
Oh, for sure. Very predictable.
Right. For years, you could just rely on a few standard algorithms to manage blood pressure, lipids, blood sugar, and you were generally delivering the standard of care. But today,
Mm.
the clinical landscape is it's shifting underneath our feet on almost a monthly basis.
Yeah, it really is. We are operating in an era where the pathophysiology is finally so much better understood, and the pharmacology has suddenly, caught up to it.
Crazy how fast it's moving.
Exactly. General internists are now deploying therapies that were, well, previously confined to highly specialized endocrine or lipid clinics.
Which is exactly why we are taking this deep dive today. So if you're a busy resident catching up between rounds, or an attending physician looking to synchronize your practice with the absolute latest cardiometabolic protocols, this conversation is tailored specifically for you.
We've pulled together a huge stack of comprehensive clinical texts today.
Yeah, we've got material on metabolic syndrome, the 2019 ACC-AHA cholesterol guidelines, and of course, the newest obesity management protocols.
Right.
And our mission here is simple. We're going to completely bypass the basic anatomy. You already know that. We want to deliver a high-yield, peer-to-peer clinical update. We'll cover the precise diagnostic criteria, the exact pharmacologic dosages for this new GLP-1 and GIP era, and the specific management algorithms for complex lipid disorders.
And I think a really critical starting point here is recognizing that before we can even initiate these advanced pharmacotherapies, the diagnostic criteria themselves have totally evolved.
Oh, absolutely. The old rules don't quite apply the same way.
Right. The older NCEP ATPII criteria have largely been superseded by the harmonizing definition of metabolic syndrome, and that significantly refines how we measure the primary driver of insulin resistance, which is central obesity.
That shift is huge, going from a universal waist circumference to ethnicity-specific cutoffs.
Yeah.
It changes the screening fundamentally.
It really does.
Like under the harmonizing definition, white men meet the criteria at greater than or equal to 94 centimeters. But for South Asian and Chinese men, that threshold drops to 90 centimeters.
And for Japanese men, it falls all the way to 85 centimeters.
Right. Meanwhile, the cutoff for white and African-American women sits at 80 centimeters, whereas Japanese women are screened at 90 centimeters, which is, a rare instance where the female cutoff is actually higher than the male cutoff for a specific demographic.
Yeah, those varying thresholds aren't just arbitrary. They directly reflect the pathophysiology of regional fat depositions. We're looking specifically at the metabolic toxicity of visceral adipose tissue compared to, well, just subcutaneous fat.
Because they behave entirely differently.
Exactly. Subcutaneous fat drains into the systemic venous circulation. Visceral fat, on the other hand, drains directly into the portal vein.
Okay, let's unpack this a bit, because the clinical implications of that portal drainage are massive. Think of visceral fat as a toxic factory built right next to the liver's main supply lines, dumping free fatty acids directly into the system.
That's a great way to visualize it.
Whereas subcutaneous fat is more like a harmless storage shed out in the suburbs. It explains why our Asian and Asian Indian patients who tend to accumulate visceral fat show higher METs prevalence at lower waist circumferences compared to African American patients who predominantly store subcutaneous fat.
If we connect this to the bigger picture, recognizing this phenotypic difference is a critical clinical red flag for early screening in normal weight patients from high-risk ethnic backgrounds.
Yeah, it's not just about the BMI anymore.
Not at all. And the biochemical bottleneck here involves lipolysis. In a completely healthy state, insulin profoundly inhibits lipolysis in adipose tissue. In fact, that inhibition is the single most sensitive pathway of insulin action in the entire body.
So it's the first thing to break.
Exactly. When early systemic insulin resistance develops, that vital braking mechanism fails long before we see overt hyperglycemia.
And then the portal circulation is just suddenly overwhelmed.
Right. The adipose tissue begins indiscriminately releasing free fatty acids. That FFA flood reaches the liver, directly stimulating the overproduction of VLDL particles and triggering hepatic gluconeogenesis.
It's a vicious cycle.
It really is. Simultaneously, those circulating fatty acids impair insulin-mediated glucose uptake in skeletal muscle. So, the free fatty acids themselves are actively worsening the insulin resistance that caused their release in the first place.
Which makes that ethnicity-specific waist circumference such a massive red flag for early intervention. If you have a patient from a high-risk demographic with a normal BMI but central adiposity, Relying on a standard visual assessment means you're going to miss the disease process entirely.
You have to identify that visceral accumulation.
Right. Because the treatment algorithms have shifted dramatically. We're no longer waiting to treat the downstream hypertension or the elevated A1C. The primary therapeutic target is now the actual adiposity driving the entire cascade.
Which brings us to the updated pharmacology.
Yes. Let's examine this. Specifically, the precise dosing required for the GLP-1 and GIP receptor agonists.
Well, the precision of the dosing is really where the clinical nuance lies. A standard diabetes dose will not achieve the central satiety effects required for significant weight loss.
You really have to push it.
You do. For example, with liraglutide, which is an older GLP-1 receptor, agonist internists are very accustomed to maxing out at 1.8 milligrams daily for type 2 diabetes.
Right.
But to achieve the roughly 6% weight reduction seen in the obesity trials, you were required to push the dose to the 3.0 milligram formulation. The drug basically must reach sufficient plasma concentrations to penetrate the blood-brain barrier and hit the receptors in the arcuate nucleus of the hypothalamus.
You absolutely need that higher concentration to drive central appetite suppression, not just, peripheral incretin effects in the pancreas.
Exactly.
And then we step up to semaglutide. Dosed at 2.4 milligrams weekly, we see trial data showing a 14.9% average weight loss over 68 weeks, which was huge until tirzepatide completely redefined the expectations.
Oh, tirzepatide is a game changer.
As a dual GIP and GLP-1 receptor agonist, dosed from 5 milligrams up to 15 milligrams weekly, the reduction in body weight ranges from 15% to an astonishing 20.9% in patients starting with a mean BMI of 38.
The synergy of that dual agonism is just fascinating. While GLP-1 suppresses appetite and slows gastric emptying, the GIP component appears to enhance the GLP-1 effects centrally, while also improving the lipid buffering capacity of white adipose tissue peripherally.
It's incredible.
We are looking at a 20% reduction in body mass. I mean, we're pushing medical therapy into the efficacy range that was previously reserved solely for bariatric surgery.
And as transformative as these injectables are, internists still have to navigate patients who present with contraindications or tolerability issues or, frankly, access barriers.
Cost is a huge issue.
Right, so that requires familiarity with the older weight loss arsenal, which comes with some pretty severe clinical red flags.
Like naltrexone bupropion.
Exactly. Naltrexone bupropion extended release can yield about a 10% weight reduction in responders, but the bipropion component lowers the seizure threshold. It is strictly contraindicated in patients with any seizure history.
You can't even consider it.
No. And it also drives up sympathetic tone, meaning it's completely off the table for anyone with uncontrolled hypertension.
And then we also have orlistat, which takes a purely gastrointestinal approach by inhibiting pancreatic and gastric lipases. It basically blocks the absorption of about 30% of dietary triglycerides.
But the side effects are notoriously awful.
Oh, they're terrible. Clinically, it only provides roughly 4% additional weight loss compared to placebo, and it's notorious for causing severe steatorrhea, flatulence, and fecal urgency. The discontinuation rates are very high.
Okay, so what does this all mean for the older drugs? With semaglutide and tirzepatide dropping weight by 15 to 20%, is there any clinical justification left to subject a patient to the GI misery of orlistat? Or is it basically a dinosaur at this point?
The tolerability profile is undoubtedly poor. However, orlistat does retain a highly specific, evidence-based niche, and that is the prevention of type 2 diabetes.
Oh, right. The conversion rate.
Yes. Clinical data demonstrates that in patients presenting with impaired glucose tolerance, orlistat significantly reduces the conversion rate to overt diabetes. By directly inhibiting enteric fat absorption, you blunt the postprandial lipid flux that exacerbates hepatic insulin resistance.
So it's very targeted.
Right. We don't prescribe it for blockbuster weight loss anymore. We prescribe it for targeted metabolic preservation when the newer agents just aren't an option.
The focus remains on the metabolic cascade rather than, the absolute number on the scale.
Yeah.
And that metabolic focus is definitely expanding. We are seeing these incretin therapies demonstrate profound benefits for metabolic-associated fatty liver disease, or MAFLD, even though it isn't an explicit FDA indication yet.
The liver benefits are striking.
They are. They're reducing hepatic steatosis simply by resolving that visceral fat reservoir.
Diffusing the source code, as you mentioned earlier. But even when significant weight loss is achieved, the accompanying dyslipidemia is often remarkably stubborn.
Yeah, fixing the weight doesn't always fix the lipids.
No, it doesn't. The lipid derangements require their own intensive management. Following the 2019 ACC-AHA cholesterol guidelines, the internist really has to know exactly when to layer on secondary therapies, and critically, when the lipid profile requires specialized orphan drugs or even apheresis.
Let's start with the basics. Statins remain the undisputed foundation, right?
Absolutely. If you have a patient aged 20 to 75 with an LDL cholesterol level greater than or equal to 190 milligrams per deciliter, a high-intensity statin is mandated immediately.
No messing around with low doses.
None. That means initiating atorvastatin at 40 to 80 milligrams or rosuvastatin at 20 to 40 milligrams daily to achieve at least a 50% reduction in LDL.
But when high-intensity statins fail to reach the clinical target, we utilize adjuvants. Ezetimibe is the standard second-line agent. It blocks biliary and dietary cholesterol absorption at the brush border to add another 15 to 20% LDL reduction.
And beyond that, bempedoic acid is becoming an increasingly common option. It inhibits ATP citrate lyase, which is an enzyme upstream of HMG-CoA reductase in the cholesterol synthesis pathway.
Right.
Combined with ezetimibe, it can drop LDL by up to 35%. But there is a crucial prescribing caveat here. Bempedoic acid competes with uric acid transporters in the kidneys, specifically OAT2.
Which means it can precipitate hyperuricemia and acute gout flares.
Exactly.
And given that insulin resistance inherently decreases renal uric acid excretion, metabolic syndrome patients are already predisposed to hyperuricemia, making this a highly relevant drug interaction to monitor.
It's a huge red flag to watch for.
Definitely. Moving from LDL to triglycerides, the clinical trigger points change. If fasting triglycerides exceed 500 milligrams per deciliter, the immediate treatment priority shifts from cardiovascular disease prevention straight to the prevention of acute pancreatitis.
Because the sheer volume of chylomicrons and VLDL in the plasma at those levels can physically obstruct pancreatic capillaries.
It's terrifying. It leads to ischemia and the release of highly toxic pancreatic lipases. Interestingly, though, while a triglyceride level over 150 is a diagnostic criterion for metabolic syndrome, aggressively lowering triglycerides has not been definitively proven to reduce ASCVD outcomes on its own.
Right. It remains a point of heavy debate whether hypertriglyceridemia is directly atherogenic or merely a biomarker for the broader, highly atherogenic insulin-resistant state.
It's a chicken or egg scenario.
Exactly. Regardless, when you need to drive down triglycerides alongside statin therapy, fibrates are frequently deployed. And here is a non-negotiable prescribing rule. If you are combining a fibrate with a statin, fenofibrate must be used instead of gemfibrozil.
Yes. That comes down to the pharmacokinetics of glucuronidation. Gemfibrozil competitively inhibits the specific glucuronidation pathways and the OATP1B1 hepatic transporters that clear most statins.
It's a dangerous mix.
It causes massive toxic spikes in statin plasma levels, drastically increasing the risk of severe myopathy and rhabdomyolysis. Fenofibrate utilizes a completely different metabolic clearance pathway, avoiding that dangerous interaction entirely.
And then we also have high-dose prescription omega-3 fatty acids. They offer another potent mechanism for hypertriglyceridemia, dosed at 1.5 to 4.5 grams per day to achieve a 25 to 40% reduction.
But the clinical trial data there requires some really careful interpretation, right?
Very careful. The Reduce Pargesi and Angelus trials both demonstrated significant ASCVD risk reduction. Notably, both of those trials utilized formulations containing only eicosapentaenoic acid or EPA.
Right, just the EPA.
Conversely, the Strength trial utilized a combination of EPA and docosahexaenoic acid, or DHA, and that trial was actually terminated prematurely for futility.
Which is wild. The DHA component may actually raise LDL levels slightly, potentially offsetting the cardiovascular benefits of lowering the triglycerides. So isolated EPA is definitely the evidence-based route.
Absolutely.
Here's where it gets really interesting on a practical level, though. Patient adherence to high-dose omega-3s is frequently derailed by a single adverse effect, eructation, or, those awful fishy burps.
Oh, yeah. Patients hate that.
They despise it. But clinical protocols often utilize a simple, highly effective intervention to combat this, having patients freeze the omega-3 capsules.
Really?
Yeah. It alters the release kinetics in the stomach, largely eliminating the eructation side effect and completely rescuing patient compliance.
That is a phenomenal clinical pearl. Just freeze them. But we also have to address the extreme end of the lipid spectrum. Homozygous familial hypercholesterolemia, or OFH.
The orphan drug territory.
Right. These patients harbor biallelic mutations in the LDL receptor pathway, meaning standard statins and even PCSK9 inhibitors often yield negligible results. General internists really must recognize when to escalate to specialist interventions.
Because the pharmacology here bypasses the LDL receptor entirely. We're looking at three specific agents. Lamidipide is an oral inhibitor of microsomal triglyceride transfer protein, or MTP. It prevents the assembly of VLDL in the endoplasmic reticulum of the liver, reducing plasma LDL by about 50%.
And then there's mipalmirsen, which is an antisense oligonucleotide that binds directly to the mRNA encoding apolipoprotein B, blocking its translation and cutting LDL by roughly 25%.
But both of those agents force the liver to retain lipids it would normally export, leading to a predictable and severe side effect, profound hepatic steatosis.
Right, which brings us to the newest biologic, evinacumab. It's a monoclonal antibody administered via IV infusion every 4 weeks that inhibits angiopoietin-like 3, or ANGPTL3. By blocking ANGPTL3, it unleashes the activity of endothelial lipase and lipoprotein lipase.
And because its mechanism is completely independent of the LDL receptor, it can slash LDL by 50%, even in patients with zero functional receptor activity.
It's remarkable.
But when pharmacotherapy is still insufficient to prevent devastating premature atherosclerosis, the final escalation is extracorporeal LDL apheresis.
And the referral cutoffs are rigid.
Very. Patients must be on maximally tolerated combination therapy. If their LDL remains greater than 200 milligrams per deciliter with established coronary heart disease, or greater than 300 without CHD, apheresis is indicated to physically filter the ApoB-containing lipoproteins from the plasma.
Recognizing those apheresis thresholds is vital for the internist. But, if we pull back to the broader metabolic syndrome population, the failure to control the upstream obesity and dyslipidemia inevitably forces the physician to manage severe downstream end organ damage.
Mostly in the liver and the vasculature.
Exactly. The hepatic burden is staggering. Up to 65% of patients with metabolic syndrome have MAFLD. As the lipotoxicity and oxidative stress overwhelm the hepatocytes, the disease progresses into MASH, metabolic dysfunction-associated steatohepatitis.
And MASH is just exploding in prevalence.
It is. The clinical data suggests that due to the sheer prevalence of insulin resistance, MASH is on trajectory to surpass viral hepatitis and alcohol as the leading cause of end-stage liver disease and the primary indication for liver transplantation.
The vascular consequences are just as complex. The pathophysiology of hypertension in metabolic syndrome is characterized by a really fascinating divergence in cellular signaling.
Let's break that down.
So, in a healthy endothelium, insulin binds its receptor and activates two distinct pathways. The PI3K-ACT pathway stimulates nitric oxide production, causing vasodilation. Simultaneously, the MAPK pathway stimulates endothelin-1 production for vasoconstriction and signals the kidneys to increase sodium reabsorption.
Right, that's a balanced system.
Usually, but insulin resistance doesn't blunt those pathways equally.
Exactly the opposite, right. The metabolic insulin resistance selectively abolishes the PI3K pathway. So the endothelium completely loses its ability to produce nitric oxide, preventing vasodilation entirely.
But the MAPK pathway stays intact.
Yes. It remains highly sensitive to the hyperinsulinemia.
So the vessels lose their ability to relax, while the persistent MAPK signaling actively drives vasoconstriction and forces the renal tubules to aggressively reabsorb sodium. You end up with a hemodynamically clamped system dealing with volume expansion.
It's a perfect storm for hypertension.
And clinical texts note this exaggerated sodium retention phenotype is particularly dominant in Caucasian patients with metabolic syndrome. Given this specific pathophysiology, managing the blood pressure requires targeting the renin-angiotensin-aldosterone system. ACE inhibitors, or ARBs, are the undisputed first-line antihypertensives.
We also have Finerin now, a novel, non-steroidal mineralocorticoid receptor antagonist that provides a highly targeted mechanism to block that aldosterone-driven sodium retention and fibrosis, particularly in patients with diabetic kidney disease.
But what about addressing the peripheral insulin resistance directly? Thiazolidinediones, specifically pioglitazone, are potent PPAR gamma agonists. They enhance insulin sensitivity in skeletal muscle and the liver by fundamentally altering fat distribution, forcing lipids out of the toxic visceral and hepatic depots and into the safer subcutaneous storage.
And meta-analyses consistently demonstrate that pioglitazone reduces atherosclerotic cardiovascular events and improves hepatic histology in MSH.
The mechanism makes total sense, but here's my question. The risk-benefit ratio of PPAR gamma agonism is incredibly difficult to navigate in practice.
It really is.
Pioglitazone activation in the renal collecting duct massively upregulates sodium channels, causing severe fluid retention. Furthermore, it biases mesenchymal stem cells in the bone marrow, to differentiate into adipocytes rather than osteoblasts, which significantly increases the risk of bone fractures. So how does a physician justify prescribing a drug that reduces the risk of a heart attack but actively precipitates congestive heart failure and osteoporosis? Are we just trading a heart attack for heart failure?
What's fascinating here is that it requires an exceptionally narrow therapeutic window and completely flawless patient selection. Pioglitazone is absolutely contraindicated in any patient with a history of heart failure or a high risk for fractures.
You really have to thread the needle.
You do, and frankly, as the newer incretin therapies demonstrate their ability to resolve hepatic steatosis and improve systemic insulin sensitivity by eliminating the adipose tissue entirely, the clinical reliance on TZDs is fading.
That makes sense.
The algorithmic preference has decisively shifted toward agents that reduce total body mass rather than drugs that merely redistribute it while causing fluid overload.
Why? We want to dismantle the visceral fat depot entirely, not just, relocate its inventory.
Exactly.
All right, let's distill this deep dive into a rapid-fire clinical recap for your next patient encounter.
Okay, first, abandon the universal waistline. Utilize the ethnicity-specific waist cutoffs, such as the 85-centimeter threshold for Japanese men to identify ectopic visceral fat early.
Critical. Second, recognize that the obesity pharmacology requires specific dosing. Liraglutide demands a 3.0 milligram dose to cross the blood-brain barrier for weight loss, and tirzepatide's dual agonism can drive up to a 20.9% weight reduction at the 15 milligram dose.
Third, if you are treating hypertriglyceridemia alongside a statin, you absolutely must select fenofibrate over gemfibrozil to bypass the glucuronidation overlap and prevent severe myopathy.
Good reminder. And finally, for your HoFH patients, memorize the LDL apheresis thresholds. An LDL greater than 200 with coronary heart disease or greater than 300 without it, despite maximally tolerated multi-drug therapy.
Those specific inflection points will fundamentally alter your management of the cardiometabolic cascade.
Before we wrap up, though, there is one final, highly provocative concept buried in the research text that we haven't touched on.
Oh, the gut microbiome stuff?
Yes. We have spent this entire discussion focusing on synthetic peptides, dual receptor agonists, and monoclonal antibodies. But the clinical literature briefly points to the gut microbiome. It highlights that an increased ratio of firmicutes to Bacteroides species in the intestines is strongly linked to the underlying etiology of metabolic syndrome.
It's wild to think about.
It leaves us with a fascinating question to ponder. As we master the deployment of GLP-1s and ANGPTL3 inhibitors today, are we only a few years away from treating severe insulin resistance not with laboratory-synthesized peptides, but by prescribing highly engineered, targeted bacterial colonies to fundamentally rewrite the microbiome's ratio?
It challenges everything we assume about metabolic pharmacology. I mean, we might eventually be managing the flora to manage the phenotype.
It truly changes the paradigm. The ultimate diagnostic tool for metabolic syndrome may never be a clean black and white image or a lidded panel. It might end up being a microscopic snapshot of a bacterial ecosystem deep within the gut.
Very true.
Thank you so much for joining us on this deep dive. Take these mechanisms, apply the updated algorithms on your next clinical shift, and we will catch you next time.